Welcome to the Tarrant County Medical Minute podcast.
Hi, my name is Dr. Omar Salad. I'm a co-host for the Tarrant County Medical Minute, brought to you by the Tarrant County Medical Society. Joining me today is my other co-host, Brian Swift, the EVP of the Tarrant County Medical Society. Also with us are Catherine Keaton and Dr. Stuart Pickell. Today's episode, we're going to talk about, one of our prized projects we do here at the Medical Society, Project Access, which Catherine and Dr. Pickell are intimately involved with. So, Catherine and Dr. Pickell, if you can give us a little information about yourselves.
Sure. I'm Catherine Keaton. I have been here at the Medical Society and Project Access since 2011. So coming up, I joke that I got to start at the most fun part, the month we saw our first patient. So I've been here ever since then. Really enjoyed just working with the program from the ground up and getting it to where it is today. I grew up here in the area, graduated from Texas Wesleyan University, and love serving Fort Worth.
And I'm Stuart Pickell, and I grew up in Virginia. I came here originally in 1987 as a minister after graduating from seminary. Always wanted to be a doctor too, so went to medical school in Dallas and then did a residency in internal medicine and pediatrics. In the meantime, I had married a Texan, and so we spent a year in Nashville. Realized 20 minutes after we moved there that was a mistake, and then got back to Fort Worth as fast as possible. So I've been in Fort Worth since 2001, and I've been involved with the Medical Society from the beginning. I was involved with this before it was this. We had what was called the Indigent Care Advisory Committee that your predecessor had started, Robin Sloan had started, and just to try to pull together all the different clinics that take care basically all primary care clinics, because that's mostly what the charity clinics can do, and to try to find out what the common needs were and the barriers. And out of that, the same thing kept coming up. We don't have access to specialists. We can't get minor procedures done. And but then Robin retired, you came, and then this sort of blew up after that, blew up in a positive way after that.
Right. So thus Project Access began in our quest to focus specifically on specialty care. And that's what we're going to talk about and explain why it is so important to get people fixed, healthy, and on their way to enjoying a great life. And that's what specialty care does.
Yes, for sure.
So we've got physicians tuning in, Alliance members tuning in. Everybody hears about Project Access. So let's get a little more detail about it. Describe the model. Who are the partners you work with? How do you get physicians involved? Explain it from ground up for us.
Well, we've all had hospital or minor surgeries or major surgeries done, and you have to think about every single aspect that's needed to get a procedure done. You need, usually starting with your primary care physician, to diagnose or at least suspect a medical condition that requires a different specialist. You require that specialist. You go to his or her office to get officially diagnosed, get a workup, see if you need a surgery, which is mostly what Project Access does. When you need the surgery, you need a hospital. You need anesthesia. You need your preoperative imaging done, sometimes preoperative labs. During surgery, you are likely to need pathology done afterwards. And if you're having certain procedures done, you may need physical therapy after. So for our surgical patients, we have to have all of those things in place in order to fully serve a surgical patient. So we had to go get all these partners, and Brian and our original medical director, Dr. Jim Cox, and other members of the advisory board and the startup board were instrumental in getting leadership at the area hospitals on board, getting the anesthesia providers at each of those hospitals on board, and getting all of the little tiny partners that you may not even think of until you need them to see Project Access patients. And then, most importantly, you have to have the physician volunteers. So we are so fortunate to be in a position where, as the Medical Society, we have access to the membership, and we can ask them if they will see a set number of patients per year. And that's one of the beauties of volunteering with Project Access. Any individual physician can say, I will see X number of patients per year, and then we won't ask them again if they reach that number. I'd say the average physician sees or volunteers to see 5 patients a year. They may or may not get up to that 5 depending on the need, but my theory is that if every physician volunteered to see 2 patients per year, we could meet the complete need in Tarrant County.
Dr. Piquel, you're the medical director. When did you start with Project Access, being the medical director?
As medical director in 2020. I
2020.
mean, I was part of the proto,
Prior
when
to
we
that.
first started, but
Yeah.
yeah, I was not as involved for the
Uh-huh.
10 years or so in between. But in 2020, I was asked to be medical director when Dr. Cox was wanting to step back.
So, what patient qualifies for Project Access, and where do you all get your referrals from mainly?
The referrals come mostly from the charity clinics that are in town. There are a dozen or so in Tarrant County that will supply. It doesn't have to come from one of these clinics. So, I mean, patients can
Examples of those charity clinics in town?
Mercy Clinic, Beautiful Feet, Cornerstone.
Okay.
Mission Arlington,
Mission Arlington.
Grace
yeah.
Grapevine.
We're going to leave somebody out. But there's a dozen or so that do these, and they run the gamut in terms of how organized they are. I mean, some of them can provide very comprehensive primary care services, and some can't. And they serve different populations. So a lot of our population, are the patients that we take care of, are undocumented residents of Tarrant County, because in Tarrant County, the county hospital system doesn't allow undocumented patients to access their network for primary care and for specialty services. I mean, they can go there on an emergent basis, but that's part of the problem. We're trying to keep routine minor conditions from becoming emergent ones. And so that's one of the gaps that we were able to fill, especially for that particular population.
So, a referral comes in, you review it, and
So for the process, yes, they'll go to their clinic. Usually, they go to their primary care clinic, which is one of these charity clinics. The referral will be placed. It goes to Catherine's team, and Catherine's team will vet their. There's all these different criteria, some from us, some from our that are determined by our funders, but some are also determined by the facilities we use. So as far as their income and others, you know more about that than I do. But
They have to live in Tarrant County. We only
okay.
serve Tarrant County. They have to have no insurance coverage whatsoever. And for our purposes, that includes Medicare, Medicaid, and also includes JPS Connection, which is the county indigent care program. Those are the 3 main requirements to being a Project Access patient.
And then once they clear those hurdles, they get sent to me, and then I review the medical record to see if it's an appropriate referral. And I'd say, 85, 90% of the time it is.
Okay.
Every now and then we'll get one that it looks like they didn't really, the problem wasn't as bad as they were making it sound, and they probably didn't need to come for a referral just yet, or they weren't able to document that this was really needed. In some cases, there just needed to be a little bit more workup done before they got referred for a specialist, because we don't want to send someone to a specialist and have them do what should have been done before it got there.
Correct.
Right.
Yeah.
So,
Yes.
so we want to make sure we are respectful of the time that the specialists
Yes.
and surgeons are putting into this.
Well, and we also do have limitations. We aren't able to do everything. And for example, we got a referral a couple of weeks ago for a man with an extreme case of a skull fracture, and due to the acuity and what was involved, that is beyond what we are able to do. And I would say that most of the time that isn't the reason that we aren't able to assist, but it does come up and it does happen.
And there are things that we don't do, obviously.
Yes,
we
we
do
do
not
have
do
some
emergency
exclusions.
care.
No.
We do not do things like cancer care. We limit our things. Again, I think what's really important is we focus on a set of problems. It could be a hip, it could be a cataract, it could be hernias, it could be those situations where we can get the patient into the program, get them fixed. And why is that so important? It's because most of the people that we are helping have jobs. They have families. If the mother's sick, the whole family is sick. If the dad can't work, the whole family suffers, right? And so we need to get these problems solved, because guess what? We can have a huge financial impact on the front end where we're getting these simple surgeries done and save from people showing up in the emergency rooms. I think that's what most people have frustrations right now, is when you go to the emergency room for serious things, right? You want to be able to access that. And if we can redirect to take care of these problems, I think there's a huge opportunity, really financial opportunity, to help people on the front end, that they can go back to their lives and working and doing the things that contribute to the community.
And I think an important point of that too is the patients that we serve who are going to the emergency departments, they aren't doing that because they have access somewhere else and just don't utilize it. When they're having a gallbladder attack, or a woman is having a gynecological bleed, that may be their only option, and the only cure is to have a procedure. And if they don't get that procedure, they are going to end up back in the emergency room.
We've had that happen, for instance, with dysfunctional uterine bleeding. Woman goes, and she just gets a pint or two of blood, and then they send her back. But she's going to keep coming back until she has the procedure.
Problem solved.
Right.
Yeah.
Well, the immediate problem is solved, but
Yeah,
not the
but
bigger
not
problem
the bigger
that's causing
problem.
the problem.
Yes.
Right,
Yes.
right. And we've had that situation many times in Project Access, that particular one.
So how many patients do you all serve a month on average, or a year?
Oh, I'm going to give you a year number.
Yeah, it changes, right?
It
The
does
referrals.
change. We serve about 200 patients a year.
Wow.
That's not 200 surgeries, but we're not isolated to surgeries. We have other non-surgical needs. We also may help a patient find a primary care clinic. Maybe they just need assistance with their diabetes, getting that under control. So we serve them by establishing them. We don't just give them a phone number and send them on their way. We help them set up their first appointment with one of our partner clinics and get them there. Some patients may only need some imaging, and that's what they need in order to make their correct diagnosis or something like that.
Yeah.
So 200, but not all surgical. We do approximately, and it's going to be way increased this year, I'm very excited, but we do about 50 to 60 surgical cases a year.
I can't imagine how much planning that is on your end to coordinate a surgeon, anesthesia, post-op nursing, post-op care, recovery.
It can be
mean,
challenging.
yeah.
It can be.
But that's why we're a one-stop shop, right? We kind of consider ourselves, so we make it easy for our physician volunteers
Absolutely.
to not have to deal with all the issues. We say, look, if you are willing to volunteer, all we need you to do is show up, and we're going to handle all the other things. And that's really one of our huge things that we focus on. Make it easy to volunteer.
Well, and one thing we haven't mentioned that's important is for our volunteers, these patients are scheduled in the course of their normal workday at their regular office. The Project Access team has a contact in each office to send a referral, so they are identified as Project Access patients. But the physician doesn't have to go anywhere besides just the exam room. Omar has seen Project Access patients before.
Yeah.
They're just in his regular schedule.
Yeah, no. It actually feels good because, like, you're working with the team, and right, so I'm getting a referral from a fellow physician, let's say to do electrodiagnostic studies, from an orthopedic surgeon who's volunteering his time. Based on my study, maybe volunteering his time now to do a carpal tunnel release or, some procedure. So why can't I do my part? And I tell this to a lot of young doctors, get involved when you're young. You actually have a lot more clinic time. You have plenty of clinic time when you're young. It's a good way to connect with other physicians and get your name out there. And they know, hey, you did this for our patient. You did this, we're all part of one team. So I think it's invaluable for young docs to get involved with.
And to your point, I probably wouldn't be able to utilize our hand surgeons if I wasn't able to get an EMG for the patient. So it wouldn't even matter if
we
I
all
had a
need
hand surgeon.
to work with each other. Yeah,
Exactly.
Yeah.
So I was going to say, just related to that, I don't want to beat a dead horse on that, but one of the things that before Project Access was here, there were a lot of doctors want to volunteer and give back to the community, but their only options were to work in the primary care clinics. And an orthopedic surgeon, and, neurologist may not feel like they're able to do that or really want to do that. This gives them an opportunity to provide the services that they actually are expert at providing.
That's
and then,
a
like
great
you said,
point.
in the convenience of their own offices, so they don't have to, if they want to do primary care, that's great. Happy to have you. But many of them would rather do what they do, and it's a lot more convenient if they can do it in their own office and not have to spend half a day going to a charity clinic.
You couldn't go to a clinic and do an EMG, could you?
No, they need to come to us where the machine is. But to your point, like, we'll get asked to help, hey, can you go volunteer at this charity health fair, health fair. I don't need to be listening to heart and lungs anymore. Right. I'm not the expert of that. There's, so let me do what I do. And so you guys provide that opportunity for us to give back. So what are the biggest challenges that you guys are faced with right now?
Procedure space.
Well, yeah, procedure space. I was going to ask you if anything surprised you about being medical director.
Oh, really? Were you? And I was going to say no, but now that you've mentioned it, the lack of procedure space. I mean, you can look at all the different barriers to getting from point A to point B. Point A being the patient who needs something, the point B is it's done, right? Okay. And Catherine's already identified all the different things that go on. There's to some extent, that's a lot of just kind of fitting pieces in the right places. But you have to have places to put them. So when we look at what is, we have plenty of patients, so that's not the problem. We have plenty of doctors, actually. Now, we could use some physicians in some specialties, and we can always use more because we have some people who
Please still volunteer.
We're not saying, we still need physician volunteers, but that's not really where the bottleneck is. The bottleneck is finding a place to have procedures that we can do, because that is all over the map and entirely dependent on the institutions that run those spaces, whether it's an OR or an outpatient ambulatory surgical site or something like that.
And we are not in the business of credentialing. We have nothing to do with credentialing. So if someone volunteers, we are only going to schedule and request that surgery be done where that physician already has privileges. Okay. The idea being they may do 3 or 4 surgeries that day. Hopefully 2 or 3 of those are paying patients, and then there's one charity patient thrown in there. So for that reason, that does sometimes limit on who can volunteer if where they have privileges doesn't participate with us.
And I think one of our biggest frustrations we've always had is that one piece, is that we do have, we have talked to hospital CEOs, we have talked to the people in the community that have the space. I always thought these operating rooms are going 24/7, that there is no space. But the fact of the matter is there are tons of opportunities to utilize the resources we have here in the community. It's just getting those that could help us out on the facility side to give us some more opportunities to perform these surgeries by their own physicians in their hospitals that want to volunteer and get them through. And I think, again, the savings, the cost benefit analysis is great, and we could do a lot of great things with a lot less resources if we started thinking on the front end rather than the back end.
One of the things that we've been able to do more recently, a lot of students, graduate students, have gotten interested in working with us, which I think will be very helpful down the road, because then we'll get a body of research that demonstrates the value. Of course, they're exploring interests that they have, but I think taken together, we're going to be able to put this together in such a way that we can identify, what is the cost savings. People, it's hard to assess the value of something that doesn't happen, right? So a patient who might need a hysterectomy is not able to get a hysterectomy because they don't have access. We don't have access to the surgical space for that, and they end up going to the OR or the ER multiple times and get a transfusion every time. ER costs, transfusion costs, and all those, and they start to add up over time. If we just done the hysterectomy, and then they still end up getting the hysterectomy. So if we were just able to get the hysterectomy when they needed the hysterectomy, we could have prevented all of those downstream costs from occurring in the first place. But it's but to my earlier point, it's difficult to set value on something that hasn't happened yet. So we keep waiting for something to happen. Going to the ER, going to the ER, going to the ER, going to the ER, then crisis, emergency surgery, and then you've expended a whole lot of costs where it would have been cheaper to have addressed it earlier.
So, so OR space is a limitation. What about funding for caring for patients on your end?
As far as funding, our cost and our budget is really low because these physicians are volunteering. We're not paying hospitals. We're not paying anyone for the services provided. That's one of the greatest strengths of our program. This is all pro bono, done out of the goodness of everyone's hearts. There is still a cost to running a program.
Which is the staff cost.
Which is the staff
mainly.
cost.
But when you're talking about, let's get really specific, when we are talking about a budget of a couple $100,000 a year, let's say if we could raise that much money, just think about what $300,000 would translate to in the millions
Absolutely.
from a care standpoint.
Well, and that's more money equals more staff equals more patients going through more quickly. And while we are talking about OR space, that would also allow for more focus on cultivating relationships that could lead to that. And also, we have a tagline that we use, $1,000 saved my life. And the cost for our patients really is more in the $1,300-$1,500 range per surgical patient. But for $1,000, someone can sponsor a patient and really cover most of the administrative costs. That is not money going to anyone besides the cost of us administering the program to the patient. And that includes instances where we may need to provide transportation to a patient who can't get there, particularly for our ophthalmology patients. A lot of our ophthalmology patients, their cataracts or their retinopathy or something is so severe they can't drive to their appointments, or maybe they need a medically certified interpreter at their appointment because they don't speak the same language as the medical staff. So that is all rolled up in there. You could get someone that hysterectomy for about $1,500.
You know what I love? When I've seen Project Access patients, you guys actually make it easier on us specialists because I actually get all the clinicals and everything. That doesn't always happen normally. You know, you get a referral on, what am I seeing this patient for? Where are the notes, this, that? But you guys do a great job of making it so easy. Just look at the notes, go treat the patient, get you the information, and it's taken care of. And so I appreciate, you guys making it so easy on us. And
Great to hear, because that is absolutely the goal.
Yeah, no, it is absolutely run flawlessly, in my opinion, from me having worked with it.
Those clinicals all come from our partners, right? From the clinics that are referring through us. So we're happy to put it all together.
But you guys make sure we get it. A lot of times when a patient shows up and there's no referral, dealing with private insurance or whatnot, and it's frustrating and it kind of waste your time. Like, let me get this. I need this MRI faxed to me and all this. But when they do come from Project Access, I can assure you, you get everything you need to take care of the patient. So that's been a nice thing. Okay, so we've got physicians listening to this.
Yes.
Some of them may not be involved with Project Access today. They want to. They're listening to this. Donations, getting involved. I mean, what can they do?
Do you want to go first, or do you want me to go first?
Well, I mean, volunteer. Call
Volunteer.
Catherine. Email.
If it's at the website, the volunteer form's on there too.
Absolutely. And so, we'd be happy to have anybody who is interested, who is able to practice here in Tarrant County.
Are there any specialty needs that we're looking at right now?
Our top 3 referrals right now, and this can be a little fluid, but the top 2 are always the same. General surgery, hernias and gallbladders, gynecology, usually hysterectomies, ovarian cysts, dysfunctional uterine bleeding. And then right now, we're getting a lot of hip and knee replacement patients. And those can be a little trickier than some surgeries because we do have to obtain the implant as well. That being said, we still use dermatologists and rheumatologists and hand surgeons and fill in the blank, things that I can't even think of right this second. So if you are a specialist of any kind, please reach out to me and we can probably find a patient for you.
We had the podcast party. We had a lot of residents come to that party. You got up and talked about Project Access. And so a lot of them came up to me afterwards and say, hey, we want to get involved. We've got residencies all over the city now. Residents can get involved with care.
Absolutely.
Obviously, under supervision of their
Correct.
attending physician and all that.
So their attending would have to sign off on that, of
Yeah.
course. But yes, absolutely.
And look at the opportunity, right, that presents. We have 2 medical schools. We have all this opportunity that we're producing. And we get back, just think about the young people that would love to be doing more procedures.
They need it.
They need it.
They want it.
Right?
Yeah.
They want it.
Yeah.
And so this is an opportunity again for the facilities to be able to step up, give these training to the residents that they don't have, right? They're always looking for it. And that is a way to fire up, right, a young group of physicians that are just coming in and demonstrating not only their skill sets, but the value of community, the value of giving back. And we have such a great group here at the medical side. That is why I think our project has been so successful, is that we do have a lot of docs that want to volunteer. Now I'm going to say one last thing, and I think it has to be said. There are facilities in town that, if you are a physician that do work at a JPS or a Cook Children's, they are not able to volunteer at
That's
their
correct.
hospital.
Correct.
I'm correct about
You
that.
are correct about that.
So if they cannot do, what other way then they can they contribute? And I would say they can give with their dollars, because even though we'd love to have you, again, the block is your facility that is not allowing us to see the patients at their facilities.
And it is very limiting when we do get pediatric patients who don't qualify for Medicaid.
Wow.
We have an 8-year-old with a hernia right now that I'm searching for a physician to be able to see, and I don't think we're going to be able to help her, unfortunately, which is a real shame. But the other way they can help too, Brian, is of course with their dollars.
Right.
They can also help by advocating for us with their leadership, and
Yes.
and one voice isn't going to fix that overnight, but many voices over time could change that over time.
Right.
Yeah. Yeah, I didn't even think about that. That's eye-opening there. Okay, so one last question here. This is a unique program. Who else is doing this around the country?
No one.
Nobody.
As far as
Not
we're
the way we're
aware,
doing
no one else.
There's a number of places that have like primary care network type things, and we had that too, but
Yeah.
they weren't really networked together. I mean, really, this all came out of that that advisory committee, I think. I mean, it sort of predated Brian being here, but we get together and what are the needs? Well, we need to have simple procedures done so these people can get back to work and get on with their lives.
One of the, and again, not to get into the, there's something called 1115 waiver, which is money that comes in from the federal government. And part of the reason the 1115 exists is to have innovative programs that tailor programs that work in each individual county. This program probably would not work in Dallas. There was, back in the day, we learned actually how to do primary project access from our friends in Dallas, but Dallas was focused on primary care only. And when we realized that we had a great charitable clinic community here, and what was the piece missing, we didn't want to duplicate primary care. We saw the niche in specialty care, because Tarrant County is a unique community that has a great opportunity, and we just fit in that space. And I don't think a lot of communities have that ability to do what we're doing here.
I agree, and also we have so many hospitals here in Tarrant. It's so easy to spread the wealth, especially the more who participate, the easier it is to not send all patients just one place.
Right.
And to Brian's point, we have a couple of real superstar hospitals, and we have some that participate a little bit less, and we have some that participate
Right.
Not at all. But the more who participate, the more we can spread it out, the less the burden is on each individual hospital and even physician.
Right.
It's amazing, the program. I mean, I've learned a lot just sitting here, and it's made my brain, firing on many cylinders. Like I never really thought about that specialty care not coming together in other counties like you guys have been able to do, quarterbacked by a primary care physician.
Right.
I mean, it's just amazing. We all work together and help our patients out, and to Brian's point, keep the cost of care down to help our city, and prevent unnecessary ER visits like Dr. Pikel's talking about. It's incredible.
I view this as a service to physicians, and
Yeah.
I'll tell you why. Because, as Dr. Pikel was saying, so many physicians want to give back. Well, if they're hindered by having to be a social worker or a case
Yeah.
manager on top of being a doctor, they're not going to be able to do much.
Yeah.
But if you can walk in a room, see a patient, and tell me what's next, my team can do the social work element of it and just allow you to be a doctor.
Yeah. Any parting comments for our...
No, I'm sorry.
No,
I go ahead.
No, I was kind of made me think about something, and I think it's great that a lot of people, we get into global health and we'll go on these mission trips overseas, which is awesome. But there's an awful lot of need right here in Tarrant County.
Right.
Yeah.
So if you're interested in, you don't want to go to, Malawi or someplace like that, you want to do something closer to home, there's plenty of opportunity to do that right here in Fort Worth.
Well, I sent a
Tarrant
patient
County.
to your office last week, so you'll have to let me know if we live up to our
you
past
guys always
standards.
have. And,
Okay.
we have a rule in our office that, all our physicians sign up and do their part, and they're all happy to. And, if it's on your schedule, you do it. And there's we're happy to help out. And that's what's cool about Tarrant County Medical Society. There's so much support from the medical society for this effort.
Absolutely.
Even at the medicine ball, the alliance is supporting it. I mean, we're all one big family working together for patients selflessly. Dr. Pikel's a Gold-Headed Cane Award winner for good reason, for all of the
Absolutely.
work he does
That's right.
for our patients over here, and seeing him in meetings here, taking time out of his day, just to help patients out. He can do that. We can all do our part too. So,
Absolutely.
yeah.
And I'll just want to reiterate, there's no number too small. If you say you can only see 2 patients a year, that's fine. See 2
Absolutely.
patients a year.
Yeah. So we can donate where?
At our website, which is kind of new, it's www.tcam.org. You can give very easily on there. You can also volunteer there. You're also welcome to reach out to me directly, and I know that my email and information will be listed with the podcast.
Okay. Anything else, Brian?
We are extremely proud of this program, and we only expect our program to get bigger and better. But that starts with our physicians volunteering, giving of their dollars, and like I say, our partners out there in the community that maybe needs to dig down a little bit deeper and reach in and help us out. Let's get this done. It's a great
Exactly.
program.
Okay. All right. Well, thank you for tuning in. You can follow us on X, on Instagram, on Facebook, and on LinkedIn. Please subscribe for more podcasts that are informational like this. Thank you.